Welcome to Mayo Clinic Sleep Medicine Podcasts, a series for physicians, advanced practice providers, nurses, and other health practitioners treating sleep disorders or interested in learning about state-of-the-art advances in sleep medicine and sleep health. I'm your host, Dr. Michael Silber.
And I'm your co-host, Dr. Ep3. We are both consultants at the Center for Sleep Medicine at the Mayo Clinic in Rochester, Minnesota. Thank you all for joining us for today's podcast titled RLS, How to Help the Augmented Patient. In our last podcast, we discussed how the alpha-2 delta ligands are replacing dopamine agonists as the first-line therapy for restless legs. This is largely because of the risk of augmentation with dopaminergic drugs. That being said, a 2022 study showed that 59% of RLS patients are still receiving dopamine agonists, and 19% were on higher than recommended doses. What is augmentation, and how should we manage patients who've developed it? My guest today is Dr. Michael Silber, professor of neurology at the Mayo Clinic College of Medicine and Science and a board-certified sleep specialist. Mike, could you help us understand what is augmentation? How common is it? And what are one's risk factors for developing it?
Thank you, Ep3. Yes, augmentation is a very specific side effect of dopaminergic drugs used for restless legs as opposed to for Parkinson's disease. And essentially, it is the paradoxical worsening of restless legs with increasing doses of the drugs. Initially, they seem to work just fine, and then months to years later, restless legs increases, and the more you give, the worse it becomes, and it manifests usually in three ways. The first, and perhaps the commonest, is the restless legs time of onset moves earlier, usually by more than 2 hours earlier. So if before augmentation, restless legs started, say, only at 9 or 10 o'clock at night, and the dopamine drug nicely controlled it, with time, restless legs starts flaring up at 5, 6, or 7 in the evening. The second thing that happens is it often spreads from the legs to other parts of the body, most commonly the arms. And third, it stops working as well at night, and the latency increases for it to start working, and the duration of action at night becomes shorter and shorter. So patients who are getting through the night on a dopamine agonist start waking up sometimes at 1 in the morning with a terrible recurrence of the restless legs. So it's not all that hard to recognize. How common is it? Well, 2 studies, one from us here at Mayo, suggests that the frequency of augmentation in patients treated with the oral agonist pramipexole, the 2 studies have shown somewhere between 40 and 70%. That's not low by any means, but it also shows that not everyone is going to get augmentation, and that rate was, by the way, over 10 years of treatment. The rotigotine patch has probably about the same rate of augmentation, but the augmentation seems less severe, and many people are able to live with it, but not everybody by any means. The drug that's worst for augmentation, of course, is levadopa. And that's the main reason why we don't use it anymore for chronic restless legs, 80 to 90% augmentation rate. What are the risk factors? Well, it depends on the drug, as I've just mentioned, but otherwise, the most important risk factor is dosage. The higher the dosage, the greater the risk. And over the years, we've begun to recognize this. And so for, say, pramipexole, today we recommend do not go above 0.5 milligrams total dose. For ropinirole, which is 4 times more potent, I say don't go above, say, 2 milligrams. Actually, it's 4 times less potent. I say don't go above 2 milligrams generally. And the rotigotine patch, we generally want to hold at about 3 milligrams. So those are much, much lower doses than are used for Parkinson's disease. Other risk factors seem to be the duration of treatment increases risk, and low iron. So if augmentation starts developing, as you'll see in them, we first always check iron status. And the most important preventative factor for augmentation would be keep the doses low.
That's very helpful, Mike. As you were talking about levadopa and the highest risk for augmentation. Do you see a role for that medication
Mhm.
in intermittent symptoms, or should practitioners really avoid that medication altogether?
Well, that's an excellent question. And yes, for very intermittent symptoms, levodopa is fine. So when somebody, as happened actually last week, somebody sends me a message saying, I'm flying to Europe, whatever am I going to do on the plane? I say, take levodopa in addition to what you're taking chronically. And so we'd say, the 25, 100 milligram carbidopa, levodopa, single tablet, just 20 minutes or 30 minutes before you fly or before you go to that concert. um, Another patient who contacted me says, I'm having cataract surgery. And last time I did that, they had to, under conscious sedation, they had to hold my legs down to prevent me moving. And again, a small dose of levodopa often will get them through it. And there is no risk of augmentation taken just as a single dose or even once a week or something like this, but not chronically.
Wonderful. Thank you for that additional clarification in that regard. So let's consider another clinical scenario. A patient is taking zero point 0.5 milligrams of pramipexole at 9 p.m. And prior to starting this medication, he was experiencing symptoms only at night, and the drug was doing well to control them. However, in the past few months, he comes to your clinic and reports that he's starting to have restless legs earlier in the evening when he sits down at 7 p.m. to watch television. His iron studies are normal. How should we go about managing this patient?
Well, he is developing what we'd call mild augmentation, just manifesting by earlier time of onset, and his dose, zero point 0.5 milligrams, is at the upper limit of what we'd use, but still within reasonable therapeutic range for this. So what can we do? Well, thankfully at this point, he's got a number of different options. First, we could split the dose of pramipexole. Give 0.25 milligrams an hour or two before those augmenting symptoms started in the afternoon, and the other 0.25 milligrams before bed. That might not hold him in the evening, of course, and we're probably just delaying the evil day when more augmentation is going to happen. But if this patient is comfortable on the pramipexole, that would be one at least temporary way of handling it. The second thing we could do would be to convert the patient from pramipexole to the rotigotine patch. You recall I said that probably the rate of augmentation isn't all that much different, but it seems to be milder. Now, if we are converting, we have to remember the conversion figures. 0.5 milligrams pramipexole is equivalent to 3 milligrams rotigotine. So you can't say stop the pramipexole and start the 1 milligram patch, because you're going to get dopamine withdrawal symptoms, going to be a total disaster, and the patient will say, I'll never use that drug again. So that's the second possibility. And the third, if the patient has never been on an alpha 2 delta ligand, such as gabapentin or pregabalin, we could say, let's cut our losses, let's get rid of all dopamine agonists, and this is a good time to convert to gabapentin or pregabalin, as long as there are no contraindications. And we can talk about how to do that, but I think you're probably going to give me a case where it might be a better illustration of how we do that conversion. So those are the options we'd go through at that time.
So it sounds like there are definitely a variety of options, or at least a couple of options that the patient and the provider can talk about. So let us consider a case then of more severe augmentation. Somebody referred to you on pramipexole 3 milligrams daily, taking 1 milligram 3 times a day. And over the years that this individual has been on the drug, they've reported that the dose has had to be slowly increased due to worsening symptoms, which now start as early as 11 a.m. and also keep him awake for much of the night. These symptoms have also now spread to the arms. How would we manage this patient?
Well, regrettably, there are still a lot of these patients around there. You know, physicians who aren't aware of augmentation, It seems such a reasonable thing that when symptoms start breaking through, increase the dose. We do that for so many disorders, and yet that's the worst thing you can do. And this patient is now on 3 milligrams a day, which is going to be 6 times the currently recommended maximum dose. So this patient has severe augmentation and is in big trouble. So what do we do? Well, first, we want to check iron status. And if iron levels are low, and I think we've talked about this in a different podcast, we would then low, when I say low, I don't mean low, low, but I mean within the range of levels that we think this patient could benefit from, we'd give an intravenous iron infusion. Now, let's assume we've done that, it hasn't helped, or the serum ferritin was way up and we really didn't want to do that. Then what are our options? Well, we have two options here. The first is to convert this patient to an alpha-2 delta ligand, gabapentin or pregabalin. But by the time the patient gets to this state, most of them have tried it somewhere in the past and they've had side effects or it hasn't worked. And then this would be a refractory patient and we would then go to opioids. Let's talk about those two options a little more carefully. If we're going to gabapentin or pregabalin, and we should do that if the patient's never had a trial of this or if it's not contraindicated, the first thing to remember is one doesn't do a quick swap. One first puts the patient on the new drug, builds it up to what we hope will be a therapeutic level, and only then do we start reducing the pramipexole. So for pregabalin, for a patient who's not elderly, we might start on a single dose of 100 milligrams an hour before bed, and then we would fairly rapidly, every 5 days or so, increase until we get to the usual therapeutic dose of 300 milligrams, usually in a single dose. We don't worry about the earlier augmentation at this time. Our first aim is to give the patient a good night's sleep. For gabapentin, we'd start perhaps at 300 milligrams and we build up to 900 milligrams. In older people, we might have to start at lower doses, say 50 milligrams pregabalin, 75 milligrams gabapentin, and build up a little more slowly. Once we've reached what we think is a therapeutic level, if there are no side effects, we might wait another 5 days or so, and then we start to slowly reduce the pramipexole. And the whole trick of this is to do it slowly, and I mean remarkably slowly. I would reduce pramipexole at 0.5 milligrams a day once a month until they hit 1 milligram, and then we go down to 0.25 milligrams once a day every month. So this patient's on 3 milligrams, so we're going to take, 6 months or more to get this patient hopefully off pramipexole. We'll start with the daytime doses and then slowly move towards the evening doses. Now, even when we do it slowly, it's extremely hard on the patients. Restless legs often flares up despite your covering medication. It takes time, it takes perseverance. What happens if we go faster? Well, many patients will get dopamine withdrawal syndrome, which is a specific syndrome. They get horrible worsening of the restless legs, intense insomnia that can be so bad they become depressed, they become suicidal, anxiety levels shoot up, they can get sometimes nausea, vomiting, sweating, and intense drug craving for the dopamine agonist. So you've got to go slowly. And it's not easy. In fact, one recent study from Harvard, a very nice real world study looking at their experience in following just this sort of protocol, showed that 41% of their patients who were heavily augmented on ultra high doses of the agonist couldn't get off it altogether. And that's my experience as well. Many of them, they get down to perhaps 0.25 milligrams pramipexole daily. I mean, a wonderful reduction. And that's it. You try get lower than that and the restless legs flares up, and they're going to have to be on some dopamine agonist for the rest of their life. So I've talked about the patient who we're going to put on to an alpha-2 delta ligand. Now, the commonest scenario is they've tried it already, hasn't worked, or side effects, and then we go to opioids, and we do exactly the same thing, and we'll talk in another podcast of what opioids and doses, but again, we build up to what we think is a therapeutic level, and then we slowly reduce the dopamine agonist exactly as slowly as if they were on the gabapentin or on the pregabalin. And we have really a very reasonable success rate. It's not perfect by any means, even with opioids in these heavily augmented patients. And again, even with opioids, we sometimes can't get them off the agonist altogether, but we almost always can get some benefit, and they feel a considerable relief.
So between the various alpha-2 delta ligands, then Mike, do you have a preference for gabapentin, and acarbol, pregabalin? I mean, how does one decide, provided the patient has never tried any of them before, which one to go with first?
Yes, well, cost is often a big factor. Gabapentin's the cheapest, gabapentin in acarbol, and which is, of course, a slow release form. You take it once a day. The dose is supposed to be a single dose of 600 milligrams, so there is some variability. You can give less, obviously, and you can sometimes give more, even if it's off-label. And you can supplement sometimes with additional ordinary short-acting gabapentin, but it's a non-generic drug, and pregabalin is usually more expensive for patients. The problem with gabapentin is when you get above certainly 900 milligrams, some would say 600 milligrams, the relationship between the dose taken and the serum levels become very variable, and you don't really know how much you're getting into the body. The absorption's variable, and of course how much is crossing into the brain. So pregabalin I like. I just happen to have had more experience with that than gabapentin in acarbol. So when the patient, I think, can afford it and insurance will pay, I prefer to use pregabalin, but it's really the absorption issue and the cost issue.
Very helpful. Thank you. Are there any final messages that you would like to leave with our listeners today?
Well, yes. Please, please, if you're using the dopamine agonists for restless legs, keep the doses low. And that's the best way of preventing augmentation. And when a patient is augmented, it's very important to manage it in a very specific way. I see too many patients who doctors now recognize what's going on, so they cold turkey the pramipexole, stop, and then put them on gabapentin or even opioids. And it's a catastrophe, because whatever you've put them on, just plummeting down dopamine levels, and they get this horrible dopamine withdrawal syndrome. And they usually ascribe it to the other drug that's just been started and saying, I will never again use gabapentin or oxycodone because it worsened my restless legs. So it's tricky, but it can be done. But if everybody kept doses low, we'd never be in this position where we had to deal with these.
That is very, very much the truth. Thank you very much for joining us today, Mike, and to our listeners for tuning into today's podcast.
Thank you. We hope you enjoyed this podcast. If so, please tune in again through wherever you receive your podcasts as we discuss further topics in sleep medicine and sleep health. Thank you.